not actually have internet. Okay. All right. We're going to kick you guys off. We're going to do our new show and we'll pull you on in a little bit. All right, here we go. Melissa,
well, that's
what the hell's
fine. Melissa
today?
and I have done a show together before as well when there was a storm in Atlanta.
Yeah, and
so
you got
couldn't happen.
I just kept on
Heads
coming
up, everyone. This show may be interrupted by the weather. You never know.
Yeah, it happens all the time. We have limited infrastructure in the South, so you know. Anyway,
in the country.
Melissa, who's coming on this show? We have a funny show today.
We do. We have Jennifer Goldsack, the co-founder and CEO of Dime, dedicated to revolutionizing healthcare through initiative technology. And she's also a silver medalist in the rowing, for rowing for Team USA. Right? I said that right? Yes. We also have, sure, I shortened it and I still screwed it up. Dr. Bhatt is the executive director of Deloitte Center for Health Solutions and Deloitte Health Equity Institute, where he drives initiatives to advance health equity in healthcare. And then we have Mr. Matthew Halt, the founder of the healthcare blog, the co-founder of Health 2.0, and he's been playing a crucial role in healthcare technology for like 20 years or so now.
Yeah, he also maybe has a PhD in the School of Hard Knocks, but he's going to tell us some industry gossip a little bit later. So we're excited about that. All right. Okay. Let's do the news show before the Wi-Fi goes out in the South. So Melissa, we'll see you in a minute here. And this news show is pretty much 100% Lisa Berry today. Well, wait, there's Pooja, but here's us. So
what we should do, Kat, we should probably start out our show by saying like, I'm Lisa. And that's Kat.
Do you think we should?
This is the Health Tech Talk Show. Yeah.
This is the Health Tech Talk Show. Here's our slide. This is Kat and Lisa this week. Here we are. Yep, we're doing stuff. That was Melissa. I don't know. Maybe we should, maybe we don't, but maybe we'll try later. Oh yeah, Ritesh, he's on. Okay. All right. So we have a couple, there's like some people are like moving around in the industry lately. So Pooja Babra from Point of Care Partners, she announced via an email.
Formerly of Point of Care
Formerly
Partners.
She's on Pacific time, I think, in Arizona. So she may still be on her last day, but she announced that she is leaving Point of Care Partners. And she's taking a couple weeks off, and she will announce her new, very exciting executive level position with an industry organization, I believe is what my interpretation of her email. But that's awesome. Pooja's amazing. She does tons for pharmacy.
We know the truth. We know the truth. That was just that's the public version.
Is she going to work for a health plan? I don't know, but we're excited for her. But we betray her colleague. We didn't tell, I think we forgot to announce this on our show, but her colleague Jocelyn a few weeks ago, or maybe a couple months ago, announced that she was leaving as well. And she has a big time, cool job at Aetna, CVS Aetna. So that's super cool. So congratulations to both of them. We've always really loved them and we're super pumped and we're excited to hype the crap out of Pooja's LinkedIn post when that happens. And then the other thing
Pooja and Jocelyn are both like examples of like, what it looks like when you spend like a huge part of your career becoming an absolute expert in something that only a few nerds care about, but is like super important to healthcare. So shout out to them.
Yeah, it's going to be awesome. They're basically going to most likely save America as far as I can tell. So, and then also Marco, I think formerly of CDII, California, DHHS, CDII.
Marco was the undersecretary of the California Department of Health and Human Services. It's
like not a big deal. So he is now with Sellers Dorsey. Lisa, what does this mean for the California Data Exchange Framework?
Well, I don't know, man. You know, as you know, you need like a person in government who's like, this is a good idea, and I'm going to carry this one across the finish line. And I would say, Marco, there certainly is a team there. There are other folks who are involved, who've been involved in this from the California HHS side. But like Marco was a big advocate for the data exchange framework. So, big deal for him to leave. TBD. They also lost their legislative sponsor. Jim Wood retired. I think he was the assembly member from the North Coast. I think he's retired, left, he's gone. So you got to those relationships are hard to repair. You got to find new people.
Yep. Hard to replace.
Also preview for our guest, our unscheduled guest later, who my neighbor, Matthew Holt, also our neighbor now, the governor of California, Gavin Newsom, who apparently has moved to Ross, which is just around the corner from us, a very fancy part of Marin County. So what does it say to you when the governor moves out of the capital and other stuff happens. I don't know.
I don't know. It means your Instacart shoppers may run into each other at the grocery store when you're up there in your rich person land, Lisa. I don't know. I'm not sure, but I'm excited for you. It's fantastic.
Gavin lives in a fancy place. Yeah. Good stuff.
This is just an exciting thing about, apparently, as usual, one of my favorite lines is that in the United States, we have legalized corruption, and that is called lobbying. It looks like our friends at CMS voluntarily adopted policies restricted their right to claim overpayments from Medicare Advantage plans. Cool. Now we know that the $2 billion lawsuit between UHC and our federal government was that this was all the CMS decision was a response to pressure from UHC. Weird. So I would just like to say that it is true. We have legalized corruption here in America. Also, lobbying apparently works. I don't know.
I wonder, like, if they thought this would just like go unnoticed. This is not a good look, guys. Like, no shade, but like, come on, man, come on.
No shade, but maybe a little bit of shade. I don't know. I guess I would be like, do you think they had like black cars outside of like CMS career people's houses? Maybe. I don't know. There might be, maybe there's going to be some, I don't know, Lisa, we're not famous enough that anyone's parking outside our house, but the governors seem to be near yours. So
please don't, just to be clear, please don't. Please don't.
Yeah, please
not park outside of our houses.
Like we don't really. Right, I mean, you know, all 12 of our fans. At one point, some of our 12 fans may come visit us, but maybe not. Okay, yeah. Other thing here, you know, Lisa and I continue to rail on Medicare Advantage. So this is an exciting opinion piece that you can all check out in our wonderful journal JAMA. Apparently, it costs taxpayers $2,500 extra for every Medicare Advantage beneficiary. But it also looks like they have the same problems and limited service and still do not have better outcomes than
the argument that the MA proponents made was like, yes, it costs more, but we provide better affordability for beneficiaries. And if you take that away, and if the reality on the ground is that it's not actually more affordable, they're not actually paying less when they need to go to the doctor, then what's the argument again? That's kind of the question here. Why do we do this then?
Well, I don't know. But I don't know. Maybe lobbyists are at work. Who knows? Undetermined. Okay, so exciting thing about Insena, which, by the way, is the company that I work at along with Melissa. So Insena did a pretty cool survey on journalists working in the health tech industry. Matthew Holt is technically one of them. He may or may not have taken the survey. I know, Lisa, my own company did not ask us to take the survey because we aren't real media. But interesting stuff in here. There's a bunch of outlets that covered this stuff. So basically, like, you know, trying to figure out, like, do journalists even care about conferences or anything like that? There's some challenges that came up here I think are obvious, but also interesting. So more than half of journalists in our industry, our little trade industry, say they're worried about the possibility of press restrictions in the United States. Almost 9,000 jobs have been cut across multiple industries and press. There's lots of shrinking outlets. This is why the Health Tech Talk Show is so popular, y'all, because we can afford to lose thousands of dollars to bring this to you. And not all outlets can. But yeah, it sounds like basically
the only way you can do it is if you don't have to earn any money, you get no salaries, and you cover the cost yourself. That's how you can
if you have real jobs. Yeah,
you gotta have another job and another job after that too to be able to do anything like this. So shout out to journalists. You guys are awesome. Sorry that everything sucks.
Yeah. Sorry. Also, only Lisa, as per our recent discussion about data and how it's fake, only 2 out of 5 journalists say that data plays a large role in their work.
Yeah. Great.
Oh, God bless America. Also, apparently, no one goes to AHIP anymore. Journalists kind of go half and half to health and HIMSS, and it sounds like a lot of the ones that go to health also go to HIMSS. So I don't know, but this you can find this on the internet in many places. If you just Google and send a media survey, and there's some interesting stuff if you care about such things. TBD. Evelyn, maybe getting bought, maybe not. What do you think?
Just, you know, it's just interesting. People can just show up and say, hey, I'd like to buy your company. And people are like, oh shit, I guess we have to consider that. You know, like that's how it works out. That's how it goes. But apparently they got kind of a rando inquiry with real money behind it. So TBD is a big deal in the VBC data space.
Yeah, and it looks like they get hit up all the time, but it looks like this specific situation.
They're like, here's the money. We have the money. We have actual money. You have to listen to us. So, you know.
Yep. We'll see what happens. Pfizer also getting in on all the stuff like Lilly Direct and all that stuff. They now have Pfizer for all, although it did not, I only read like the first 3 paragraphs of this press release, Lisa. It looks like they are not doing GLP-1s, but they're doing like,
Pfizer does not have GLP-1s. That's correct.
Yet. But this is like COVID stuff, a bunch of like flu shots, stuff like that. You can go check it out. Interesting, maybe, I don't know, probably not going to be as profitable as Lilly Direct.
Well, so I was talking to some people last night who didn't know a lot about healthcare, but knew a bit about the general business conditions. And they were like, why is healthcare so bad? And I was like, well, big question, got to answer a lot. And I was like, so somebody's going to have to earn less money. And right now, a lot of people in the industry have agreed that PBM should earn less money. And a lot of tide has turned to say like, that's a bad thing. We should get rid of them. That's a middleman we can get rid of and get some of that money back. So if you think about like, do a lot of people agree that they should earn less money? Yes. And accordingly, drug companies are like, guess what? D2C is on its way. We're ready. And this is just the latest example of like how we're going to sell directly to customers. Customer patience.
What's the difference? I don't know. Probably a lot. Probably a lot. Okay, I just wanted to briefly mention this. Lisa and I did a whole thing about how a bunch of hospitals in Massachusetts had gotten fined big time for essentially like, it was like not great. So it turns out everybody's decided this is no longer important.
Yeah, this is pretty quiet, huh? This is a big deal. There were a couple articles about it. Basically, like if you are in healthcare, you really can't just like set up regular old like performance marketing tools that track people wherever they go. And it's really easy to do this by mistake. And some hospitals did it by mistake and they got charged. And then for this to just kind of like get dropped and go away is a little bit questionable. TBD.
I don't know. Anyway, it's gone now, so I guess we can continue tracking stuff on the internet.
Well.
This is like big news of the day. Lisa, you probably saw DEA this earlier today. This is the early Politico thing, came out in Pro. It was basically they got like a unpublished summary of a rule that the DEA is putting together that basically is like you cannot prescribe controlled substances over the telehealth. I guess it's that you can only fulfill half of a prescription of a Schedule 2 to 5 drug under this rule, which like most telehealth companies are like not into. And in general, this would roll.
Remember how you were just saying that lobbying works? I do not think this is going to go through. This has been the reason why this hasn't moved forward thus far is because there's been substantial and significant lobbying from the telemedicine industry in general. Like, and this, I mean, truly like no shade. I think it was really, really important, but like there's been a lot of pushback for a long time that has delayed the updates to these rules around, around controlled substance prescribing. So I would be surprised if this goes through. We'll see.
Yeah, everything. So I clipped this off of the screenshot out of my email, as you can see at 10:50 a.m. And there's been another update published just as of I think an hour ago that basically is like, apparently DEA and HHS have gotten in a few fights over this. HHS does not agree. There's they're expecting tons of crazy comments, and it's very unlikely this rule will go forward. And if it does, that it would hold through administration. So not great, but there's some interesting stuff that they found here. So basically you're kind of screwed. You need an in-person visit to get the full prescription. Most telehealth services do not have in brick and mortar locations. And also this down here, which I think is like an incredible, as you all know, I have a lot of opinions about one company in particular that's really, that runs basically all of our country's PDMPs. The proposal would also require providers prescribing any controlled substance to check prescription drug monitoring programs intended to prevent diversion in all 50 states. However, as our loyal fans know, there is no system linking all 50 of those.
We could figure that out. I have a better idea. Why don't we make sure that all of this information is flowing, and then let's fix the teleprescribing requirements? Let's do that. How about we solve that problem? I don't know. Call me crazy.
I feel like you need more money from more lobbyists. That's what I think. Maybe one day at the Health Tech Talk Show we'll make enough to fund that, but probably not.
Anybody who's watching wants to donate to my personal fund to lobby for actually connecting all prescriptions, let me know. Just reach out. No biggie.
Yeah. Give her a call. Give her a call. We also have a link on our website where you can give us money. All right.
Yeah.
Lisa, apparently mosquitoes are killing people with like equine encephalitis, something up in Massachusetts. Watch out, y'all.
In Massachusetts.
I think the guy was actually from the person. There was one person who's died. I believe he may have been a New Hampshire resident, but it might have been Massachusetts. But Massachusetts is, and Boston, apparently, they're like, hey, don't go outside. Not great. This is like not great, y'all. Apparently,
great. That's not great.
30%.
I'm going to Maine in a few weeks. I hope it doesn't make it up there because I'd rather not die of a mosquito-borne illness this year.
Yeah. So watch out.
Yeah.
The advice is wear bug spray. So I think that's strong. Also, back to misinformation. Journalists, no one's around anymore. They're all getting laid off because no one cares about media because they don't. But it turns out more Americans still think that, or more Americans think that COVID now will kill you more. The COVID vaccine is more likely to kill you than actually getting the disease. All these things we are increasing in amazing information. So
if
just
there's
FYI.
anyone who's watching this who believes this, like, let me know. I have had more COVID vaccines than probably most people. I am fine. I am thriving. All of my organs function. I have very little brain damage. It's fine. Seriously.
Doing great.
Doing great.
And I have had COVID more than most Americans. So we're basically on the same page. We're like doing fine.
New vaccine. Shout out to Scott Stewie. I'm just going to flag this right here.
PSA. Where'd it go? Oh, there we go.
Oh,
shit.
Are you doing
it?
Do it again. Stop.
Yeah.
Oh my God.
All right.
New vaccine available today. All right.
Public service.
The vaccine is available.
All right. Where are we going?
You can go to CVS, Walgreens, Walmart, whatever, and schedule it and go now. New vaccine.
But speaking of misinformation and public health, RFK may be Trump's public health advisor, currently in talks. So just so everybody knows, but he does want everybody to know he has never been anti-vax. So just in case that was misinformation to the American public, everything's going to be fine. We're going to be okay. Sure. All right. And with that, we're going to bring on a real guest who can tell us some things. We're going to bring on Dr. Jay Bhatt. You're the co-host, Lisa. That's different. So we're going to bring on Jay. Maybe his camera appears. He's back. All right. So this is Jay Bhatt. He is joining us from Iceland.
Hey.
So
great to be here.
And just a shout out to
undisclosed
location in Iceland. I mean, that's what I would tell people too. But just a quick shout out to Mayor Ritesh Patel, who actually reached out to us and told us that Jay would be an amazing guest. So here you are.
Awesome. Great to be here with you all. And thanks. Shout out to Ritesh as well. He's always connecting people and making things happen. But appreciate the opportunity. And have you some my good friend Jennifer on as well. So
we got all y'all on here. So it's going to be a big deal. So Jay, what are you actually doing these days? Because I looked at your website and there's like a lot of studies on there. There's like all kinds of stuff going on. What are you doing?
Yeah, so I lead two efforts at Deloitte. One is our Center for Health Solutions, which is, think of a think tank for life sciences and healthcare, where we produce insights that we can take to market and try to advance the industry. And the other is the U.S. Health Equity Institute, where we're driving social impact through both pro bono and hard dollar philanthropic investment, but also working to build the capabilities and capacity of our teams that are working with clients on health equity, as well as delivering on health equity client-based work. And then work with our Center for Health Solutions around research and thought pieces. So we're trying to advance thought leadership, activate that thought leadership for advancing better health for everyone.
Awesome. So that's like a lot. What initiative are you most excited about or proud of over the past year or recently?
So maybe I'll give you two. One is on our research side, where we're doing a lot of work on advancing the economic case for health equity. So you may have seen our study that said that health inequities cost us $320 billion as a nation today and $1 trillion in 2040 if we do nothing different. We applied that to mental health inequities as well, and showed similar numbers of impact at scale. And then I would say the other is around women's health and the mismatch around investment and need. And so we're doing a lot of work around that area with a series of pieces, identifying the important need to invest in women's health, the differences. So one of our studies showed that women pay out of pocket, commercially insured, age 19 to 64, 15.4 billion more than men. And when you add maternity care, it's 17 billion. And it's because of the way that we think about design, the different needs and supports women may require at various times through their life journey. And it's not a one size fits all. And so that's another. And then I would say from our work at the Health Equity Institute, a couple pieces. One, our partnership with collaboration with the American Cancer Society on ACS Cares, which is a tech platform to enable and support patient navigation. And the other is around working with a number of collaborators on social entrepreneurship. We know that women and people of color are not receiving the kind of investment and network and community they need to advance social enterprises that impact health equity. And so we're really supporting both largely not-for-profit social enterprises and increasingly a small number of for-profit social enterprises to see how we can advance impact there. So I just think that both on the client work that we're doing to advance health equity, as well as the work we're doing to advance the industry and help executives think differently about some of these issues, it's really exciting. And one of the frameworks that people really like is that you can think about the domains of action. Organizationally, what are you doing for your people and talent and your policies and procedures and process that impact health? The other is, and that can impact human sustainability for the ability for people to thrive in your organization. And then products and services, what's the lens you have through your products and services? So I'll give you, we were just talking about COVID, pulse ox, a good example. Where that medical technology can still evolve and hasn't gotten to where we need it to be. The other is community. So that's the impact of the collaborations of community in the ecosystem is vendor, supplier diversity, policy, and advocacy that you all referenced earlier as one of the levers to impact the ecosystem. So found that's good. And then, of course, what would it be if I didn't talk about Gen AI and a health tech talk show? So
I don't know what would happen.
Consumers, which is really interesting work we're doing with consumers and their point of view on Gen AI. They appear positive about it, but express reservations about sharing personal data and the need to implement, robust regulatory systems and oversight and solving for biases. But I think that there's good examples, of how to address this. But trustworthy and ethical AI and tech is critically important.
Yeah.
Jay, is Deloitte involved in any of the various public-private governance things? I forget if you're on CHI or any of those other, efforts to develop frameworks and assurance testing.
I'm not formally involved in some of those coalitions. I know that our team across Deloitte is engaged with them. And, we have a trustworthy and ethical AI framework as well that we often engage the market with, and it has a lot of this similar kinds of approaches to addressing it, and find that it's really important. And you got to think about governance, building consumer trust and engagement, gaining the workforce buy-in, and then scaling the solutions. And I think of Gen AI as a platform and an approach. And when you do that, trustworthy and ethical technology is an important foundation.
So I did look at a little bit of, you referenced some of this women's health work. I saw you all have a report on maternal health. And I think the women's health, at least what I read, was about increasing investment in women's health. So I think the awareness stuff is great. What actual actions is your team recommending to increase investments in women's health, improve maternal health? What are the actual concrete go forward things to do?
So I think one is looking at aligning investment with needs, where there's most need in the various areas that impact women's health. By looking at the data, and we see that there is at times a mismatch. So that's one. The other is benefit designs that account for the needs that women have. So, for example, screening mammograms are covered under the ACA, but once you find something on it, it becomes diagnostic, which may be an out-of-pocket expense. So that is an example. If that's not accounted for in the benefit design, then potentially someone may be paying out of pocket for that. There may be, other symptoms that and conditions that require additional support and needs that may not be accounted for. So that's, I would say, the other. And then the other is on clinical trials, the data that's needed. And when you look at what data we have, there's not enough in particular conditions that we need to make good, sound decisions about both diagnostics and treatment. So those are some. And our report certainly goes into more.
Yeah, Jay, we loyal fans will know we've talked about that specific issue around the screening mammograms and the diagnostic mammograms. I've experienced that now. One time, luckily the last one didn't have any follow-up needed, but it's truly incredible. And of course, as you know, those decisions are made through the U.S. Preventative Health Services Task Force, and their latest sort of output said, like, not enough information, not enough data. We don't feel confident enough for whatever reason to say that, you need a certain type of, like, you're almost guaranteed to need a certain type of follow-up or a different type of screening for dense breast, for example, like ultrasounds or a 3D mammogram. So if you go into that screening mammogram knowing that you have that, you're very likely to need to follow up no matter what. And they're just like, well, not covered. It's not going to be considered screening. It's not going to be recommended to be covered under the ACA for screenings. And, that is such a funny, like, barrier to say, well, it's part of your screening, but now it's diagnostic. So you're going to be paying out of pocket for it, even though you aren't using healthcare resources just for fun at that point. Like, you're in the process of getting screened for a disease, which was kind of the whole goal of having those screenings be cost-free for people, so that they actually go and get screened and don't delay or avoid care as deductibles get higher and higher. So it's a tricky one. We definitely need more data, need more evidence there. I need help making those cases, right? There's a line where data goes from, like, is it just neutral data? Or are we trying to make a case that there's something that we believe is true and we expect that it will help improve health and it will help, like, reduce equity gaps, but how do we get there?
Yeah, and so to that, the little teasers that we've got 2 new studies coming out in September that build on both the women's health work that we have done, as well as when businesses and organizations lean into health equity, you can create value, and that's really just the best health for everyone. And how do you go about doing that? So.
Yeah.
Nice.
Yeah, I think
a couple of comments here to show, just from Nadine Peeber, around mental health inequities potentially getting worse with that DEA proposed change. Luckily, it doesn't seem like that's going to go through, but it's certainly solving the bigger problem. That's one. And then Ritesh also noted this, that Deloitte has a really cool tool for hospital CIOs to see what their AI maturity level is. So Ritesh is shouting you guys out, Jay.
Yeah, he's hyping.
Great.
He's a hype machine.
Yeah. No,
so Lisa and I talk a lot about friction in the healthcare process, right? And I think there's there's some like outrageous number of people who never receive follow-up care based on even if it's recommended. It's something like 38. It's a lot. It's a lot of people don't actually go, even if it's like, hey, you might have cancer, you might have breast cancer, go get this XYZ test. Many don't, right? And it's sometimes because of cost. It's sometimes because of it's just like freaking confusing, right? So yeah, I mean, what do you think about that? Like, what are ways to actually solve that problem? Like, remove some of the friction from the system, especially for patients who like just they don't have time to sit there and like actually Google and figure all this shit out or watch the health tech talk show.
Yeah, so I would say that part of this is about redesigning work. When we think about our workforce, and redesigning that work with technology is just not about efficiency. I think it can also restore meaning and purpose of healthcare work if done right. And that's another recent piece that we've done around technology and restoring purpose and meaning in work. And so stabilizing the workforce with quick wins, evaluating the results, and reinvesting into longer term transformation. And then this approach we have of reimagining the workforce, and the workplace. And I think that's an important place to start. And I also think that we're seeing that consumers are demanding more from the system. And as that continues to drive forward, it'll help address some of the friction challenges you point out. It is, in creating convenience, addressing affordability and out-of-pocket costs for people is going to be increasingly important, along with education and addressing the misinformation and disinformation that impact people's decisions around care and prevention.
Yeah. Strong move. So question for you, you told us what you're most proud of. Like what's like, I mean, Deloitte's like big, right? You probably get a lot of exposure to different problems. What is like the big, like what's your biggest concern? Especially with like the elections coming up, like what are you most concerned about? Like what's going to hold us back in healthcare?
I would say affordability is one of my biggest concerns. I still, we see costs continuing to go up for people and in the system. And the other is workforce. If you don't have an effective and appropriate workforce, and then I would say sustainability and the impact of the environment on sustainability within healthcare delivery and the environment's impact on health outcomes. So I think that those are all really important. Then really technology enabling us to get the things right that we need to, is the other thing that I hope we don't lose the gains we've made in a lot of different places when it comes to healthcare. But we also have continued challenges, where friction impacts outcomes, inequities impacts outcomes, affordability impacts these outcomes.
Yeah.
I don't know how we I don't know how we can even move forward with the level of affordability in the system right now for people, right? It costs the country a huge amount of money and it costs individuals a massive amount of money. And the result is simply—
Do we need more lobbyists?
No, get rid of them. I mean, don't, but do. I don't know what to say. Like, we just, as I've complained before, we just did open enrollment, or we selected plans at my tiny organization. We are not big. We have a PEO. So we're like in this hybrid market. And, it's almost impossible for us to provide plans that have anything lower than a $3,000 deductible. And that's like relatively generous when you look across the landscape of like what employers, or even employers, aren't able to offer super generous plans anymore. Right. So like, what do you do? And that means people can't afford to go get care. They literally have to sit there and go like, well, I guess I got to come up with $3,000. Not great.
I think there are, bright spots. And the question is this a problem? Yes. Is it solvable? Yes. Is it scalable? That's the question. Where how do we make the things that we know have addressed cost and affordability, work at scale? And so that's, I think, part of our collective work, as an industry.
Yeah. All right, Jay, we know it is Friday night in an undisclosed location in Iceland, and you are ready to go out. So tell our loyal fans, all maybe 14 of them, on the topic of affordability, like what do you think like general humans can do to improve that, if anything?
I think
start a fund for lobbying.
Lean into prevention and talk to your friends, family, colleagues about the importance of it. I think we can help wherever from our own perch, try to find places where we can reduce friction and, support the workforce. I'm a practicing physician in a community health center on the south side of Chicago, and I'll tell you from, the community health center view, workforce for populations that are historically disinvested or marginalized or uninsured, underinsured, require this workforce. And I think to Ritesh's point, health is critically important. We did a piece that showed that we have what we need today to get nearly 20 years more health span, better quality of life, along with longer quality of life. and we've just got to make that happen.
Awesome. Well, thank you for joining us. We're going to let you go off and continue to be on vacation, and we will, I'm sure, have many follow-ups from our many fans as to what they can do to save America, per your advice. So thank you, and hope you enjoy.
Thanks so much. Good to see you both.
Great. See ya. All right, we're gonna bring out. We got real quick here. We're gonna have like dueling accents if Matthew shows back up, and then we're gonna kick Matthew off for a little bit and just talk to Jen.
Dueling accents.
He's like not even here. I just, you know.
This is actually exactly what happened the last time I met the three of you. Where I came, I was allowed like half a cup of tea, and then I was told to piss off. I went,
no, it was
true.
probably
JP Morgan this year. This is exactly.
Yeah. Anyway, no, that is true. We did.
You three had important stuff to talk about.
Yeah, we had big things to talk about. I had to give all that money to Jen.
If I knew you were handing out money, I would play it around.
I was just handing out money, as you know. That's also, you know, just losing money on the talk show, giving money out. So anyway, but yeah. So Matthew, we're gonna kick you off for a second because we're gonna talk to Jen first, and then listen, God bless you. So you're gonna go away for a while. But everybody meet Jen Goldsack, who I think Lisa actually introduced me to.
You did? Yeah, I did. A lot of cool people you met because of me, Kat. Let's not forget it.
I know. Everybody knows that. Everybody knows that. Also, I just want to point out that Jen has her Olympic rower arms out. Yeah. And I am jealous. Yeah. So great job. A+ situation.
Jen Goldsack, Michelle Obama.
Who even are you? Oh my God. Who are you? Actually, you know, before you answer that, I just want another shout out to Mr. Matthew Holt. Is that I actually watched your interview on the healthcare blog with him before I think I ever talked to you. And I was like, oh, this lady's like kind of a badass.
Yeah, I know. It's a pretty good trio this afternoon on a Friday afternoon before a holiday weekend.
Yeah. Everybody's here.
And the fun thing I did this summer before we talk about actual, health tech, I went to the Olympics in Paris and it was amazing. It was wild. And I'd never been as a spectator before. And Paris never looked so good, and saw everything Macron and Snoop, which was amazing. So yeah, did it right.
That was amazing. That is actually, Snoop was one of the reasons I actually tuned in all the time, was just see like what else happened with that guy.
They did the marketing right. They realized that he was someone who would have broad appeal to people who may not be watching otherwise. And the way that he threw himself into it was just tremendous. But we were watching the women's soccer, the USA Japan in the quarterfinal, and he walks in about 10 minutes into the game, and the entire sort of area we were sitting in goes, na, 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 na. And I was just like, can you imagine if you just like walked into a sports venue and everyone just started singing in unison, like one of your songs? It was incredible.
I mean, it happens to Lisa and me all the time. Like we walk in and people are like, oh my God, it's a health tech talk show. That's exactly what happens. So, okay. So tell us the story. So you're the CEO and the co-founder of Digital Medicine Society, AKA Dime.
Yeah.
We know you with CancerX, but you guys do like a ton of stuff. So just like tell us the story. Also, make sure to tell us a story about how you decided to like just make this thing happen, because we love entrepreneurs.
It's pretty cool.
All right. Well, that's a big question. So so I competed in the Olympics in 2008, and I was on the US team despite the accent, and had just moved to the US, trained for a few years, retired, was here. And I'd always thought I was quite employable, but as it turns out, the fall of 2008 was not a cracking time to be looking for a job. So
right.
Philly, I'm a nerd. So I'm a research chemist is my actual training. So scientist reporting for duty. And the only place I could get a job was at Penn, at the hospital, and they were willing to use my research skills. And what was incredible with that was I sort of rode the wave of digital coming in again and again. So high tech, then went from Penn down to a community health system in Delaware, really petitioned to hire the first 6 data scientists. No one could really understand why we might need them instead of, but we have statisticians, and I'd argue I was onto something. And then, did the same thing on the clinical trial side of the house for a few years, was at a couple of startups. And by the end of this, really believed deeply in the possibility of the digitization of healthcare to actually address a lot of the challenges that you were chatting about with Jay, not as a silver bullet, but there are new tools in the toolbox that we've never had access to before. And we've been trying to bend the cost curve for 20 bloody years. We've been trying to do all of these sorts of things, precision medicine, learning health system. How long have we been talking about this? And now there are new tools. And Lisa, work that you do means that data isn't locked in a manila folder in a file cabinet anymore. We can access it with the appropriate permissions. We have compute power that we've never had before. And we have the opportunity to do all sorts of different communications that allows us to overcome the maldistribution of physicians and the people who need them. So, this is the opportunity to really think differently about what healthcare is. And it was funny. There was a conversation I was having with a few people where, we were sort of saying, look, there needs to be this sort of convening function for all of the different stakeholders that need to be at the table for the digitization of healthcare. Oh, maybe there should be a society. And, me being a wise ass, the last bloody thing the world needs is another society. That's a terrible idea. And by the way, surely someone's done it. So as it turns out, no one had done it.
You were like, they haven't.
Exactly. I was like, I'll just go and help. And as it turns out, oh shit, no one had done it. And, I was the fool who
white space.
Exactly. So it's really been a journey, but we have so many incredible partners, Incenna being one of them. We are effective because the industry trusts us to solve hard problems. They tell us what the right problems are, what the market's ready for. And, you were talking to Jay about some of this too. One of the things that we think about all the time is this notion of a double bottom line. We are you don't bootstrap a charity. My husband will come in at like 2 a.m. and be like, here you are, still bootstrapping that charity. And then he just goes back to bed. And, you don't do this unless you really believe in making a difference. But one of the things that we've been, I think, very practical about at Dime, and this sort of extends to our other sort of collaborations, is you've got to give people a reason to do it. Altruism is never going to be enough. We need to spell out what good looks like, how you get there, and you need to give people a reason. Otherwise, we're just screaming into the wind. And I think we've been effective because we've been quite pragmatic to that extent.
Yeah. And you're not like a baby nonprofit. I mean, you got like, what, 50 people working for you or something?
Yeah, that escalated quickly, 56, 57 or something, yeah.
Yeah, that's awesome. Well, there you go. You're like, you can't be bootstrapping it that much.
Yeah, exactly. Although sometimes they do have a moment where I'm like, how that happened.
How much money is in my personal bank account today?
Exactly.
That's awesome.
We love a doer. We love a doer, someone who sees a problem and is like, I guess I've got to do it. I guess it's me.
Yeah.
I mean, I was about to say that's never been a problem, but that might be my problem. But yes, that is definitely, I am a card-carrying member of the Get Shit Done Club.
Yeah, there you go. Well, some of the stuff that I know Leslie from Incenna and I have really loved about what you guys are doing is some of the financial toxicity work. Like we were just talking about with Jay, like affordability is like total bullshit. Like it's like not affordable. I think one of Nadine had a comment up here too about like, it's paid $200 to get like a mammogram or something. Like that's a lot of money for a lot of people. So can you talk to us about some of that work? Because I think you guys have been putting out a bunch of stuff about it recently, that program.
Perfect timing, just this week. It's almost like we planned it. We didn't. So that's exactly right. So one of the things that we are very, very proud to do at Dime, sort of across our portfolio, we co-host CancerX, which with our colleagues at Moffitt Cancer Center, with OASH, with, I've got to get this right now, ASTP and OMC, and then obviously the White House. So this is the public-private partnership that sits under the Cancer Moonshot that is charged with harnessing the power of digital innovation to achieve the goals of the Moonshot. So that is reducing the number of deaths by 50% in the next 25 years, now 23, and also really trying to ensure that as we do that, we make sure that we address the inequities and the burden of cancer for all people. So as we set up CancerX, which is now about a year and a half ago that we launched, it's an exceptional community of nearly 200 organizations that have said, put their hand up, come to the table and say, we want to be part of this. We believe in this vision. We're here, put us to work. We've been running accelerators. We've been doing a couple of different data sprints, really thinking about getting the US CDI Plus for oncology right as that's issued. But the initial project that we started, pre-competitive collaboration, was really to say, as we think about the promise of digital tools in cancer care and research, how do we actually think intentionally about reducing financial toxicity and improving equity? That this is not a bolt-on, that this isn't something where we say, because this pisses me off all the time, people ask the wrong questions, right? oh, digital, what about equity? I'm like, do you have any idea how inequitable healthcare is now? How could you possibly make it worse, right? So the question that I always ask is, instead, if you're making these investments, if you have digital strategies, if you're doing the damn thing, how do we actually make sure that we're bringing everyone with us? So we released a whole tranche of resources, sort of core competencies for hospitals, so they could really think about leveraging their digital strategies to sort of reduce inequity and really start to address financial toxicity. And then just this week, and I'm really proud of this, and it gets to the whole notion of the double bottom line, an ROI calculator that open access, like absolutely brilliant. Designed it with our colleagues at Huntsman in Utah. And obviously the whole project team, we used all open access data. And so you can go and say, if I invest in this strategy, what's it going to do for the financial toxicity of the people with cancer that I'm here to care for? And what is it going to do for my bottom line? And it actually passes into, okay, if it does this for medication adherence, how much do we save? Because we're not going to see escalations in care. We're not going to have to do follow-up. How about missed appointments, right? We were just talking about that when screening becomes diagnostic. So all of that has been captured, and there's a whole blueprint that you can follow. So we give you the reason why you should do it, then the how, and 12 different case examples from our community, which, as I said, is exceptional. And we've got receipts too. This actually works. So that's what we put out this week, and it's the real essence of, both DIME, but CancerX in this case. It's talk about a community of doers.
Yeah. And this was one of the initial things that I think attracted Leslie and me to work with CancerX, right? To become a part of the community, was that, we are really focused on underserved communities. And cancer is one of those things, like, people like financially can barely recover from, if they recover at all. So super important, awesome work. And shout out, I know Rochelle Prosser is here in the comments.
Fantastic.
A ton of work there. Yeah, she's doing a ton of work making sure that patients have more equitable access to treatment, kind of across the board information. So, Lisa, what do you think about financial toxicity? What do you think about everything?
As loyal watchers of the show will remember, I wrote an entire chapter in the book about artists remaking medicine about financial toxicity. So I am really not a fan and care about it a lot, is the summary. Really not a fan. Currently, I will say there are some government sometimes works for you, not all the time. But, there is a new rule that has, I think, now gone into effect fully, where bills cannot be on your credit report, medical bills. And so I think that's in effect right now. I got to double check. Someone who maybe knows can check my sources, but I think it's actually gone into effect now. And that has sort of empowered me personally, who got kind of a crappy bill for something that I thought was wrong or incorrectly calculated, to just challenge it and be like, I guess send me a bill, but I don't agree with it. So let's go through the appeal process. And I'm not really that fussed. So that's one aspect of it, right? Getting medical bills and getting calls from collection agencies, that's really stressful and part of financial toxicity in healthcare. But it just gets exponentially worse when you're dealing with serious conditions like cancer. The bills, it's not just one bill for some kind of procedure, treatment, or diagnostic, thing. It's all the bills from everyone all the time coming at you.
And traveling to centers of excellence, if you're going to be on an immuno-oncology product, then you're an inpatient. I mean, this is just, can you imagine? You're trying to hold down a job. You've got 2 kids, you've got an aging parent, and someone says the only way that we can, the frontline treatment is you now have to come and be an inpatient for however long on the other,
what are you going to do?
Russian roulette with, I am going to lose my life anyway, or I am going to die. It is absolutely intolerable. And Grace Cordovano, who you guys know and is a good friend of all of ours, she serves both as a patient in residence at DIME, which we're very proud of, but also as a CancerX fellow. And she always says we have to treat this as a grade 4 side effect of treatment. Is that the damage that is done to your financial standing, your stress, your ability, even if you recover, to recover your life fully in terms of your ability to then sort of pick up where you were, it's intolerable.
Rochelle notes that all that's good, but they still allow medical debt to be bought and sold to collection agencies and different companies who just do that. They buy bad debt bad debt from hospitals and from systems, and they go and collect it, and they get to keep sort of whatever they recover, some portion of what they recover. You can just shout out to, there's some great, organizations in space, RIP Medical Debt. You can buy medical debt too for really cheap, and you can forgive it for people. Basically, if you buy it, you can buy it at pennies on the dollar, and then RIP Medical Debt just tells them, hey, guess what? We bought your medical debt and it's forgiven. Please be healthy, please get better. And we've taken care of that part of it. But that's ridiculous, right? It's ridiculous that the system would be set up like that. It's just truly predatory. Then you have like nonprofit hospitals and systems who receive tons of government funding and tons of philanthropy funding who are going after people for bad debt. There's just so many structural, systematic things behind it that are so crummy.
Well, and the anecdotal story that I always tell, because when Matthew comes on, I'm curious for sort of his take. But obviously, if I chat to friends that sort of I grew up with or family members who are still back in the UK, and I'm talking about sort of what I do, they really can't understand the healthcare system. And the anecdote specifically as it relates to cancer is, okay, blockbuster show for a solid decade, Breaking Bad. Here's the premise of the story. 2 people in a family get cancer, and the obvious thing to do is to start a meth lab, because there really is no other choice. And when people actually pause and think, oh yeah, no one bats an eyelid, that's exactly what you had to do. Clearly, that was the path forward. That's the sort of pop culture reference to how broken it is, but how desensitized we've been. That this is just how it is. And it doesn't have to be. And I think, especially as we think now about the ability to do navigation, the ability to do virtual first care and build, whether for cancer or whatever, build care around the patient and not the clinic. And, Jay's recommendation was do sort of more prevention. If we can actually do healthcare instead of sick care, if we can actually think about using all of these technologies, so instead of waiting in the clinic for someone to present already sick with symptoms, and then healthcare is evaluated by how good are we doing a patch-up job, what if we actually say, we're going to meet you where you are, we're going to address all of these other determinants, we're going to think about a healthcare system instead of a sick care system? I don't know how we sustain our industry unless we move to that. I don't know. I don't know how we pay for it as a society. I don't know how we pay for it as individuals. I really don't.
Yeah. It's pretty wild stuff. And we know that obviously we need systemic change to really improve the healthcare system, but the work that y'all are doing is it's fixing things a little bit on the margins, which is much more than nothing. And I would like to say to all of our loyal fans who may have money, stuff like this, joining CancerX and being a member is one of the few ways you can really move the industry forward without being Johnson & Johnson lobbying and UHC and all that, right? You can actually do meaningful stuff. So check Jen and her team out. And then Jen, I do want to give you time to talk about some non-CancerX projects y'all are working on.
Yeah, so it all ties together. So we were talking about sort of maturity models. We were talking about the difference between sort of direct outreach or sort of direct prescribing and care from pharma and virtual first care. So one of the other things we launched earlier this summer was a maturity model for healthcare systems who are really struggling to actually start leveraging virtual first care as part of a true, wait for the buzzwords, omni-channel model. Right. So how can they actually think about, that's right. How can they actually think about load balancing, that the folks that they are bringing in to see their clinicians are the people who need the full length of time of the visit. They need to be inpatient. They're more complex. They might be referred for further treatment. And how can we think about well-controlled patients with sort of chronic conditions, not burdening them, meeting them where they are, great data exchange, all of these other different sorts of things. So we put that out, and that has just been incredibly well received, and we're excited to see how that's going. And one of the other things that's front of mind is, we've been talking a little bit about equity, is there's the women's health piece, but there's also the pediatric population. And this is wild.
Yeah.
Peds have been underserved forever, but also because of the way the population is distributed, the small number of sort of children's hospitals. Rock Health put out a report at the end of last year. 23% of the population are kids. It's the most diverse population. 20% of them live in poverty. Oh, and by the way, we only spend 10% of healthcare sort of dollars on children. When we think about all of the great preventative sort of work we could do, investment of the total digital health sort of pool of investment since we started tracking, it's in low single digits. There's never been, to the best of my knowledge, and I'm happy to be corrected, a successful exit of a pediatric digital health company. And so what we've been doing with Boston Children's, with Rock Health, and some other brilliant partners is actually building out a playbook for, again, Here's the ROI, double bottom line all the time. But actually, here's a playbook. Here's how you actually think about consent, assent, a changing body over time. The fact that at some point in their treatment, a kid actually has data rights, right? How do you actually think about this? How do you think about communicating? How do you think about a kid who, you know, has healthcare needs, but lives in 2 different homes? How do you think about splitting that? What if they don't have a smartphone? How could you ever use a sensor technology? All of that is being addressed, and we'll have that out later next year and this year. And I'm really proud of that too. I really think it can and should make a fundamental difference. And it's 23% of the population. There is a market there.
Yeah, that is no joke. That is wild. And I have heard those stats before. It's totally wild. And there are so many, I feel like there's a little wave of startups right now that are focused on pediatrics, but yeah, it is a tough freaking space. And comment here from Jenny Williams. Yeah, just acknowledging the whole issue with you know, financial toxicity in healthcare in general across the board. She is correct. So Jen, we are going to bring Matthew Holt back on the stage here, who appears to have gone dark.
Maybe he's like, this is a losing.
I feel like my nose off channel or whatever I was doing.
Yeah, so we just need to, I feel like we just need to keep you both on here just in case Jen wants to like say words that are beautiful compared to our amazing American accents.
Yeah.
But so Matthew, one of the things so we've been talking, the whole industry has actually been talking a lot about this NABLA thing where they were with Kaiser, they were being implemented across the board. We know tons of clinicians who are super happy. Lisa and I were actually, you know, we were being fully brainwashed with the mind virus at Epic last week. And tons of doctors were like, oh yeah, we love this NABLA thing. And then the Kaiser just announced that they had cut NABLA and now they're working with Abridge. I can barely remember that name because it seems not that great, but, so there's been some drama.
Well, slow down a little. So don't forget, Kaiser is like the former Yugoslavia. It's like, it's got some 8 or 9 unconnected pieces, including, so Kaiser, some California, some doctors there were using Abridge. Kaiser Ventures had invested in the bridge. NABLA was being used by Kaiser
physicians,
Northern California group. And
wasn't it just the physician group, right?
Yeah, but all the physicians are using it. There's a question about they're using it inpatient, outpatient, but the main place that you would need this is outpatient, right? Is outpatient.
Yeah.
General primary and specialty care. So they're being used there. They put out a report which got in the New England Journal of Medicine after about like 4 months of use, saying how great it was. And NABLA thought they were doing very well, but it was only ever a 1-year contract. So what happened was that, so 2 things. Now, Abridge raised a ridiculous amount of money in last year. So I think it was in February. I forget the number, but it was, the rumor I heard was $5 billion in revenue, something in the order of 800 million in valuation. I think they raised over 100 million. I forget. Those numbers may be wrong, but those are kind of the orders of magnitude. And at the time, they went from Epic's like showroom to their toolbox. There's Epic made up a category, right? And there was a strong rumor that Epic was taking a share. You want to come in and be our favorite child? We want a slice of you, which is kind of ironic because when Kaiser went with Epic in 2003, the then CEO, George Halverson, who I'll mention in a second when we talk about Medicare Advantage, said to Judy Faulkner, I want to share your company because I'm about to make you very rich. And she went, no, not really. And anyway, so well done, Judy, for facing down George and Kaiser, making $1 gazillion off them and not giving them a share of the company. I mean, I don't know how you get a share of a private foundation. But anyway, so 2 things happened. One is NABLA was booted out and Abridge is coming into apparently all of Kaiser permanent groups.
All of Kaiser.
Yeah.
Number 2, I would have liked to have seen, because they're Kaiser, they can do what the hell they like. I'd like to have seen them do a real compare and contrast about all the different ones they were using in anti-AI. Not only did they not do that, so we don't know what Abridge is. We heard good stuff about Abridge, and Abridge is a really fantastic product. We heard good stuff about its use elsewhere, and it's done. It's probably the dominant one that's not nuanced at the moment.
Mm-hmm.
But we don't know what the direct compare contrast within Kaiser was, if there was one done, which I don't think there was.
Right.
And my little birdies told me that there was no chance for there was no chance for an open bid. There was no RFP. This just happened, right? Internally. And then the question you get is, so Epic just having been asked by His Talk literally this week said, yeah, we did.
I just saw that.
we do have a program, and yeah, we have warrant, i.e., we asked for a share of the company to share of the future revenue. If you want to be.
Wow. Well, that's not exactly what it said. It said we front their Epic's line. I just read his talk thing. Epic's line was we front the cost for startups, and we take, I think it was a warrant. And they're like, we're not trying to own the company, but we front the costs.
They're not
we do it via a warrant structure.
This is corporate VC, right? They're taking a slice. What you don't know is the agreement.
Shout out to his talk. Seriously, though, I mean,
his talk is still like the best.
Always got the dirt.
Epic is scared enough of. They're the only. He's the only guy that Epic's scared enough to actually respond to, right?
Oh my god.
Well, amazing.
Anyway, I guess that's true.
So
that's funny.
That's the story. But I mean, look, the answer is it's a very low switching cost, right? Because ambient AI is ambient AI. They're all very similar. Nabla's a great product. Abridge is a great product. Nuances is more expensive. We don't know what the cost was. The original cost was much cheaper than Abridge, but who knows? You'll figure it out, and they'll do okay because they've got a bunch of other customers. That first big one has gone away, and it's upsetting for them.
I was like, this has like captured the market. Like everybody has been talking about this, and like, why?
Well, I think it's the one. Amazing. I mean, going back to like how screwed up healthcare is, the one thing. If you go back to Bob Proctor's book, The Digital Doctor, which he wrote in 2015, which is mostly about the introduction of Epic and how it pissed off every doctor in America, like EMRs, but Epic in particular. The thing that they all hate is having to sit there and type. Takes them away from the patients, and they don't finish. They're not fast enough, and they can't complete the note during the visit. And with ambient AI, they can just talk. If it's good enough, it writes it up. They look at it for 30 seconds to go, yep, boom, and they go home. And that's a really, it's a really amazing technology that actually helps doctors, whereas I don't think anybody else has done.
That again, we heard people came out of the woodwork to tell us that this was the actual feature. They were like, super jazzed about using that has made their lives
hours
better.
Of time saving.
People were extremely excited about that. Physicians specifically. Yeah. And I think, when have you last heard a physician be like, I love this healthcare IT? That's not a vibe you get a lot. And it's just because technology is hard for people. Like we're not good at it.
But
so
wait till the stuff that comes out of dime. They'll love that.
Yeah. Jen Goldsack taking on ambient AI scribes. What?
That's right.
Here's the funny thing about it, Matthew, you're exactly right. But there's a lesson in this for all innovators, which is when you solve a real pain point and it's pleasant to use, you're not.
People will sell it for you. They will sell it for you.
What's our adoption strategy? Healthcare executives couldn't write checks fast enough. So they're short on clinicians. They need that extra capacity, and they need to keep the ones they've got and keep them happy. There was no question. There was no sort of agonizing over, how can we drive adoption? It flew off the shelves, and it is used, and it is really sticky. And I actually think it's a good thing that the switching cost is so low, because what's always characterized health IT since
really high switching costs.
So high.
Well, I would say one more thing, which is that right now there are independent companies doing this, but the bones of being able to do this is also inherent in OpenAI, in Anthropic from Amazon, and obviously in what Microsoft and Google are playing around with. And you may well find that is going to start. And I've been hearing about this happening in the other LM stuff and some other stuff, where the dedicated analytics AI companies are getting kind of beaten out by the big guys for cheaper price. I think this will start happening I think there's a chance.
But Microsoft and Epic have a serious and significant partnership on AI. Sure. OpenAI is de facto owned by Microsoft and doesn't have enough money to keep going as an independent company.
But they might put a Bridge and Nabla out of business. I'm saying by having their own tool.
Yeah,
so Epic might do it with them or something in a combination. So this is a fast moving thing, but it's a bit like the early days of the computer, right? When it came down to now we have
the race,
strong agree,
big race. It's wild. But and also I want to shout out, I think the Nabla CEO, whose name I cannot remember, had a really great, graceful message about losing that. Like, actually, I was like, that's like a little bit of a knife in the ribs, but also like makes you sound really good. The messaging
Alexandre Lebrun, a very stylish Frenchman. He'd been practicing at those Olympics that Jen went to, and I was there afterwards. By the way, I'm following Jen around. I went to the Olympics. I went to Paris after the Olympics ended, And then I'm probably need surgery now, Jen. So I'll talk to you about that separately.
Amazing.
There you go.
I'm like, I've got a vodka and a knife. I'll do whatever surgery you need.
I'm not saying you should
There
do
you go.
it. Maybe you should. Maybe that's the way to help how healthcare costs go down. Just instead
We
of
can cover it on the Health Tech Talk
instead
Show.
of an expensive orthopedic surgeon, I get an international rower to do it for me.
I mean, I'm strong enough to do whatever carpentry you need. I guarantee.
Out of the four of us, like I would probably have to choose Jen to be the surgeon. Like if it were an emergency situation, I think I would go with her. No offense to the two of you.
Yeah,
I agree. It's definitely. I would go with her.
Surgeon, yeah.
Agree. Strong agree.
Absolutely.
Oh my God.
Really
Okay.
Clear with a hammer right now.
All right. Matthew, last parting. What parting thoughts would you like to leave our 12 loyal fans with?
One parting thought is I do have to check you two guys out because you haven't been reading George Alberson, former CEO of Kaiser, the guy who made Judy Fulmer-Rich, on the healthcare blog. Wrote twice this week, and he's a bit of a lone voice, but he's actually not wrong, which is that Medicare Advantage is actually, there's no evidence, and in fact, a lot of the data suggested by the Medicare trustees who publish this and within CMS is that overall it's cheaper than being Medicare fee-for-service because the Medicare plans actually bid at 95% of the average cost of fee-for-service in each county. Now, this is not saying that within how they get paid in that, within that capitated bid, that there isn't room for a lot of improvement in how much they charge, what they're delivering, et cetera, et cetera. So, I'm not going to say Medicare Advantage is better, but MedPAC has kind of been dominated. Who are the ones who have been saying, oh, it's more expensive? It's kind of been
talking about with the math. Math is not real.
Okay, go check the math. Now, it's all very well. MedPAC doesn't talk about the math. Go read the Medicare trustees reports. That says it's
Tell George he can come on the show and talk about it.
Come on. We can talk about his math.
Okay, George will come on the show. But what I'm saying is that this argument is not as simple as you think it is. Even if the solution is,
of course not,
put all doctors on salary and just don't put any copays for patients up front. Which
okay. This isn't the NHS.
I'm back to Jane. The NHS.
Well, I will say, as before, in whenever these VCs all get together and they do their theoretical healthcare studies and they say, if we could blow up U.S. healthcare and start again, what would we do? All of these smart finance wonks always come up with a single payer system, 95% of the time. So, I don't know, maybe there's something to that. IDK, but we have lobbyists in America, so probably not tomorrow.
Didn't say we were getting there. I'm just telling you that.
It's fine. Okay, loyal fans, it is 5:37 p.m. Eastern time on the Friday before weekend. So we're out of here.
Weekend.
Thank you, Jay. Thank you, Jen. Thank you, Matthew.
Union strong.
Great.
Union
or maybe
strong.
not. Or maybe not. All right. Goodbye.